Και ολοκληρώνουμε αυτή τη στρογγυλή τράπεζα και καλούμε στο βήμα τον αγαπητό κύριο Πετσατώδη για να μας κάνει μία παρουσίαση για την εμπειρία του στην Ελλάδα πάνω στο θέμα του μονοήρου πνευμονικού οζυδίου. Μας ακούτε?
Καλησπέρα, με ακούτε?
Πολύ ωραία. Καλησπέρα κύριε Πετσατώδη.
Καλησπέρα, βλέπετε τις διαφάνειές μου?
Βεβαίως, είναι όλα μια χαρά.
Όλα μια χαρά. I'll give my lecture to English in order for our colleagues to understand better. And unfortunately, I'm not there with you because we have a congress in Crete as interventional radiologist, and I have a lecture here. But I'll try, from my point of view, from the interventional radiologist point of view, to say what we can do for the lung. And I'm very happy to talk between a pulmonologist. It's like an MDT meeting. We work every day in a hospital with pulmonologists, with thoracic surgeons, and we do the percutaneous approaches, starting from a lung biopsy to ablation. And I have to say that especially lung biopsies are very safe. We've never seen seeding, and I think it's an everyday routine, completely safe, fast, and very cheap. So, I'll talk about our experience in Papanikolaou Hospital regarding what we can do with a pulmonary peripheral nodule. So, what we do percutaneously is we can thermally destroy lung lesions, and thermal destruction is achieved with temperatures above 70% Celsius, thermal ablation, or using cryo. We use extreme cold, minus 40 degrees Celsius, in order to destroy tumor cells. So you have RFA, which is mostly an old technology abandoned nowadays in most of the hospitals. We have microwave ablation and cryoablation, which is our standard of care now in Papanikolaou Hospital. So indications for local percutaneous treatment is patients, of course, who are just as unfit for surgery. Patients who have a primary lung cancer up to 3.5 centimeters, so stage 1A, 1B, or 1C. Patients who have a relapse after radiation therapy or surgery, which is very common. And you know that if we have an SBRT, then we can't have SBRT again because these patients already have the maximum dose, so we have to treat these patients. And also in patients with metastatic disease, these patients can be oligometastatic, have a few lesions, or can be oligoprogressive. So we see there is in time, slowly growing lesions can be treated with percutaneously ablation. So graphically, this is the lung indications for local treatment. Percutaneous treatment is patients who have an early stage primary cancer or a small lung met. A patient who has a painful bone met, we can treat this patient. A patient who has a chest wall invasion from a lung tumor, or a relapse in the field of radiation therapy. I present some cases from our experience. This is a case, an ideal patient for local treatment from us. It's a patient who has a single lesion, a small lesion, that is already is far from the pleura and is surrounded by a lung parenchyma. All lesions that we treat, I have to say, they are all biopsied before, and we have a specimen in order to have the pathologist to do whatever we want later as the oncologist want. This is a microwave antenna. Inside the lesion, we see here there is a small pneumothorax of no importance. The lesion is placed inside the tumor percutaneously, and then after 6 months, we see that the patient has developed pleural effusion with has no importance to the patient regarding his pulmonary function, and but we see it has a negative FDG uptake and a complete treatment of the tumor. This is a thermal ablation of the microwave. I have to say this because this is the old practice that we used. Another case, this is a histologically proven lung adenocarcinoma in the right lobe. The patient has the option of getting surgery, but he is old and he's not willing to have any surgery. So we did a cryoablation. We put 3 needles in the tumor. We see here the 3 cryopobes positioning very symmetrically, respecting the boundaries between every cryoprobe. The cryoprobe should be placed in the peripheral of the tumor in order to cover the whole tumor. This is the result after the ablation. We see this ground glass surrounding the whole tumor, and this is of utmost importance because this ground glass means that we've treated the whole tumor. The whole key to a good treatment is to have margins around the tumor. Like the surgeon who has to do RO margins, we have to do AO margins, and tell these patients who are coming to us that we'll have a complete treatment with no relapse. This is a follow-up. This is the ablation zone, very good after 1 month, and after 6 months we see the negative FDG uptake that tells us that we have completely treated the tumor, and the patient is completely relieved from his tumor. Another case, here we have a colorectal lung met, the same way, lesion surrounded by a lung parenchyma. Again, we used 3 cryoprobes. We see the placement of the cryoprobes around the tumor. We see very good the ablation zone and the margins around the tumor covering the whole tumor from every direction, up and down, right and left. 3 cryoprobes were used in order to create a large ablation zone, and this is very impressive. After 6 months, we just see only a scar in the lung parenchyma and, of course, a negative FDG uptake. This is the difference between thermal ablation and cryoablation. The cryoablation respects very much the lung parenchyma and just creates a small scar without big cavitation or such problems like we've seen before in the previous lecture. Another case, a patient with severe lung emphysema can be treated. Here we have a very small lung nodule. It was biopsied. It was a small adenocarcinoma. We placed inside this tumor 2 cryoprobes, either abducting the pleura. We had no problem. This is the patient 6 months later, just a scar and a negative FDG uptake. Of course, not everything goes very smoothly. We can have complications, but they are small and easily treated. First of all, we can have pneumothorax, like like we have in a biopsy. Nowadays, I don't even consider pneumothorax as a complication anymore, because sometimes we create our own pneumothorax in order to have a good ablation. But the percentage is about 40%. 11% of this, as published, require access to. We can have pleural effusion, we can have pulmonary hemorrhage, we can have pneumonia, very rare, or abscesses, but they are described in the literature. We can have bronchopleural fistula if we use thermal ablation, not cryo, next to pleura, or we can have injury to sensitive structure, especially mediastinal nerves. We have been treated very with great care tumors next to mediastinum. Here we can see some examples from our practice. We have here a patient with 2 nodules deep implicated in the lung parenchyma with these are metastatic nodules from colorectal cancer. We are placing the cryoprobes. Here we see the cryoprobes in the lesions in order to create a good ablation zone. But after we remove the cryoprobes, we see that the patient developed pulmonary hemorrhage and pneumothorax. All of this, the pneumothorax was put inside a chest drain from the intervention radiologist. We have a complete relief from the pneumothorax in the theater room. Here we see the hemorrhage, but this is what we'll tell you about cryo. 1 month later, a very good ablation zone and respect to the lung parenchyma with no other complication. The patient was discharged just 2 days after the intervention. Again, a patient with a colorectal lung mets. We see multiple mets, but all located in the same lobe. No disease in other parts of the body. So we treated aggressively with 5 cryoprobes. We did a good ablation zone. We were very happy. The patient discharged the next day. She was very good, but on the phone it says I can't breathe just 3 or 4 days later. She has a deterioration in lung capacity, low oxygen saturation, and we tell them immediately come for a CT scan. We see that there is a pleural effusion, and we see that there is like a pneumonitis surrounding our ablation zone. And this is something that we have to keep in mind, that even with a small and less aggressive, when we do an aggressive ablation, we can have a deterioration in the lung parenchyma, and this is something that has to be taken care of. The patient just took some oxygen and some cortisone for some days, and this is the final result 1 month later with no other complication to the lung parenchyma, and very good result regarding the ablation zone. In order to have to protect ourselves from any destructive complication, we use thermoprotective techniques, and this is most of the time we use an artificial pneumothorax. We create a pneumothorax in order to remove the lesion away from a sensitive structure. We can use hydrodissection in order to protect the mediastinum, or the cryoprobes can have the ability to have a stick mode, and I'll tell you what this is later. This is the nerves of the mediastinum when we treat a lung tumor. A lot of nerves, the phrenic nerve, as we said before in the lecture, very nice example, it's very important because the patient who has already severe deterioration in the lung can have a very much problem if you cause a damage to the phrenic nerve. So in order to protect these nerves and you have a lesion, we create a pneumothorax by ourselves, and then we remove the lesion away from the mediastinum in order to safely and aggressively treat this lesion. Again, here we have a lesion next to the aorta. The aorta can steal energy from our ablation zone, and the sympathetic chain is very close. So we do the hydrodissection to the mediastinum. We remove the aorta away from the tumor in order to ablate safely, and this is a final result, very good result with the treatment of the tumor. Again, a microwave ablation, the tumor next to the mediastinum, a massive hydrodissection of the mediastinum in order to protect the nerves that are close in proximity with the ablation zone. Here we see the ground glass surrounding the whole tumor, and the final result. This is a stick mode we're going to use with the cryoablation. We have a lesion here dislocated in the lung parenchyma metastasis. We can create a pneumothorax by ourselves, remove the lesion away from the mediastinum, put a cryoprobe inside the lesion, and then the cryoprobes, they can freeze a little bit, and then we can lever the lesion and move it away from the mediastinum and treat very good and aggressively the tumor. The treatment goal, of course, as I said before, from percutaneous point of view, is to complete lesion destruction. We have to make these patients have a very good result. We need margins. Margins, as I said before, is from the utmost important, and the big margins and large ablations volumes have a very low recurrence rate. This is just published from the last Congress that is used for interventional radiology. We're conducting in Greece a very big study with 2 centers, one in Thessaloniki Papa-Nikolaou Hospital and at Ikono Hospital in Athens, a phase 2 prospective trial for lung cryoablation. We have already enrolled 55 patients, 70 lung lesions, lung mets, and primary lung cancer. We have to have at least 2 years follow-up. And here we see the Kaplan-Meier scores, very good results regarding survival probability, progression-free survival probability, and metastasis-free survival probability. Regarding only Papa-Nikolaou Hospital, our experience regarding only primary lung cancer, we've treated from about 2020 to till now 28 patients. The mean size of the lesions were 2.3 centimeters. Most of the patients, the mean follow-up is about 19 months. The overall survival is very good, 100%. We have no deaths in the first year. Progression-free survival is 97%. The results are great. We had only one patient who had progression regarding a mediastinal lymph node, who probably, it was already when we did the ablation, but it was too small to recognize even for PET-CT. We had no local recurrences regarding our lesions. All patients were done, and this is very important, under local anesthesia. Only 2 patients have a very required just a drain placement, which nothing important. They just left the hospital 2 days later, and there was no deterioration in these patients of the lung function. This is very important too. So while we're using now cryoablation in our hospital, it's less painful. We can use it, we can treat the patients under local anesthesia or mild sedation. Usually we use just local anesthesia. It's less susceptible to heat sink effect than the other thermal modes techniques. We see very good the eyes and the ablation zone are surrounding the tumor. We know already the effect that we have in the tumor. It's very safe to use near main bronchus, pleura, or central located tumors because it preserves the cellular architecture of the lung. We don't see any cavitation or fistula formation, which has very bad complications. And we're able to treat even larger lesions and save ablation zones by putting multiple probes and already treating larger and more irregularly shaped lesions. Also, another field that we have to keep in mind is the oncologist's point of view. There is also cryoimmunotherapy. It's when we use immunotherapy together with a local treatment in order to boost immunotherapy and give a more like this abscopal effect. It's all discussed it's a large discussion in all oncologic meetings to do a local treatment with a combination of systemic therapy. Also, we see the advantage of the stick ball as I showed you before. And our big, not competitive because we can use everything, is ablation or SBRT. And all meta-analysis, everything published in the literature says that although our treatment is more invasive, there is no difference between overall survival between lung ablation and stereotactic body radiation therapy. And we have to say, but in some centers like Thessaloniki, we don't have SBRT. So every MDT meeting should help the patients get the best treatment regarding the expertise of each center and regarding which modality is available in every city. So hopefully, ablation is not just after SBRT. Ablation, I think, is completely equal to SBRT. So in conclusion, MDT meetings is very important to give in every patient the best approach they can have. Everything is on the table. Every modality it can be discussed. Our treatments don't exclude any other treatments. We can combine with every treatment. We can combine with surgery. One patient can have a surgery in one lung, an ablation into the other. We can combine two different ablation modes or systemic therapy to ablation. Thermal ablation techniques are very safe and effective for patients, of course, unfit for surgery. Very low morbidity and mortality rates in a population which already have very severe comorbidities. The patients that are referred to us are already very deteriorated in the lung capacity. We preserve this lung function as much as we can. If we have a local recurrence, we can go back, not like SBRT, and retreat these patients. And especially if a patient is metastatic, not in primary lung cancer, these patients that are going to develop more and more lesions. And every lesion can be treated and treated again with very good results. And of course, as I said before, we can combine with other treatments. So, the final, if we can have the good indications and we can go minimal, we should go minimal. Thank you very much. Thank you.
Ευχαριστώ πάρα πολύ για την εκπληκτική παρουσίαση, γιατρέ μου, και κάποιες ερωτήσεις από το ακροατήριο, διότι η ώρα είναι και περασμένη βέβαια και όλοι θα θέλετε να έχουμε ένα ευχάριστο τέλος σε αυτή την τριήμερη συνάντηση που κάναμε εδώ και με την ευκαιρία ως πρόεδρος και της Εταιρείας Νοσημάτων Θώρακος να σας ευχαριστήσω όλες και όλους για την ζωντανή και θερμή έτσι παρουσίαση όλων σας σε αυτό το συνέδριο. Ελπίζω να περάσετε καλά και να μάθατε περισσότερα πράγματα και όλοι μας να μάθαμε περισσότερα πράγματα. Θα ήθελα λοιπόν και το σχόλιο σας πάνω στην ομιλία του κυρίου Πετσατώδη.
Εγώ να πω μια κουβέντα, κύριε Πετσατώδη, ευχαριστούμε πάρα πολύ για την εξαιρετική παρουσίαση και κρατώ πολύ αυτό που λέτε, ότι μπορούμε να συνδυάσουμε όλα τα εργαλεία που έχουμε και όλες τις δυνατότητες στη φαρέτρα μας, είτε αυτό είναι ενδοσκοπικές τεχνικές, είτε είναι διαθωρακικές τεχνικές, είτε ακτινοθεραπευτικές, είτε συστηματικής θεραπείας και ημμουνοθεραπείας, ανοσοθεραπείας μαζί, Νομίζω ότι αυτό είναι το μήνυμα που πρέπει να βγει, γιατί ο καθένας έχει την τάση να κοιτάζει από το δικό του πεδίο την αντιμετώπιση του ασθενούς, ενώ στην πραγματικότητα πρέπει να βλέπουμε πώς μπορούμε συνεργατικά να βοηθήσουμε τους αρρώστους μας. Και σας ευχαριστώ πολύ για αυτό το μήνυμα.
Νομίζω το One Man Show έχει τελειώσει οριστικά πλέον.
Έχετε απόλυτο δίκιο, συμφωνούμε απόλυτα.
Τελειώσαμε, σας ευχαριστούμε πάρα πολύ. Καλή συνέχεια και καλή διασκέδαση θα έλεγα, γιατί είναι και Σαββατόβραδο.